So this is part 2 where we are going to discuss how to start reading an ABG in a step-by-step manner. Those who didn't watch part 1, please go through that video first before listening to this, where we discuss the basic concept of ABG. So let's start. This is an exam question. A 36-year-old man was admitted to the ICU with sepsis and MODS. So day 5 on ventilator, pH 7.2, PO2 30, PCO2 60 and bicarbonate 40. You can see the electrolytes here. Can you please try to answer this for 10 marks? Usually those who are trying this for the first time will answer like this. pH is low, so the patient has acidosis. Bicarbonate is low, so definitely the patient has metabolic acidosis. But the answer is wrong because this is not the way to answer, especially for exams. I will explain why. Suppose somebody asks you a question like, what are the causes of chest pain? How will you answer? It's better not to answer randomly with examples like myocardial infarction or pericarditis or esophageal perforation. Instead, it's better to answer with headings like cardiac cause of chest pain includes myocardial infarction and pericarditis. Pulmonary causes of chest pain includes pneumonia. Abdominal cause of chest pain include esophageal perforation. Similarly, when reading an ABG, you also need to read it in a step-by-step manner with headings. So what are the headings? First is validity. Then comes oxygenation status. Oxygenation status has 3 subheadings: PaO2, PO2 by FA2 ratio and AA gradient. Then comes ventilation status, and last is ABG abnormalities. Here in the last heading only we have to explain the acid-base status. So once more, first is validity, oxygenation status, ventilation status and ABG abnormalities. So what is validity? Before answering this, consider one more question. Suppose a 20-year-old female with no comorbidities is admitted to the ICU with pneumonia. You received a call from the lab indicating her potassium level is 7. What will you do? Your response might be, I will start giving IV calcium for membrane stabilization to prevent cardiac arrest. However, this isn't the correct answer. Why? Because why would a young patient with no comorbidities develop hyperkalemia? First, you should determine whether the potassium value is accurate. This is the first thing that what we have to do, confirmation. This potassium value could be incorrect. To confirm this, there are many ways. First, check the ECG for evidence of hyperkalemia. So the first step is confirmation. Similarly, you need to determine whether the ABG is correct or valid. So validity means the ABG is internally consistent or not. However, discussion about validities are mainly relevant for exams because modern machines we use now calibrate with good accuracy. We only discuss validity if there are doubts about whether the ABG is incorrect or not. So first is validity. So how do you calculate validity? The formula is H into bicarbonate by PCO2 should be 24. If you get 24, then you can say that this ABG is valid. So you can see here bicarb is here and PCO2 is here. And where do you get H? So you can get H from the pH hydrogen ion relation chart. This is a chart. For example, H for pH of 7.1 is 80 and for 7.2 is 60. So how to remember this chart? In exams, either you have to memorize these values or there is a simple method that we will discuss in last part where we solve problems. So H into bicarbonate by PCO2 should be 24. If you get 24, that means it's a valid ABG. So first is validity. And how to calculate validity? H into bicarbonate by PCO2 should be 24. Now the second heading is oxygenation and its status. See this patient admitted with pancreatitis, a 24-year-old male on room air. The ABG shows a PO2 of 30, that's very low, and a pH of 6.9 with bicarbonate of 5. So what will you correct first? Hypoxemia, or you will think about correcting severe metabolic acidosis? Definitely hypoxemia. You will start giving oxygen. So oxygenation is important to consider. In ABG, first talk about validity. The second heading should be about oxygenation and its status. So now we will discuss oxygenation status. It has 3 subheadings: PaO2, P-base ratio and AA gradient. So what is PaO2? It's the partial pressure of oxygen in the arteries. This measures the pressure of oxygen in your blood. It reflects the amount of oxygen gas dissolved in the blood. And then what is SpO2? It's the saturation of the peripheral oxygen, which can be measured using pulse oximetry. This is SpO2. So the SpO2 is the saturation of the peripheral oxygen measured using pulse oximetry. PO2 is what you see in the ABG. Then what is FaO2? So FaO2 is the fractional inspired oxygen, that is what we breathe in. And what is my FaO2? The oxygen content in the room, that is 21%. So my FaO2 is 21%. This is my ABG. It shows a PaO2 of 99. So how did I get this PaO2 of 99? The expected PaO2 can be approximated by multiplying FaO2, that is the fraction inspired oxygen, which is what I breathe in, into 5. So FaO2 into 5 is PaO2. What is my FaO2? The oxygen content in the room, that is 21%. So my FaO2 is 21%. So 21 into 5 should be around 100. Thus in my ABG, PO2 should be around 100. But FaO2, the fraction of inspired oxygen that I am breathing in, will change if you use different oxygen devices, and you should know the FaO2 for each devices such as nasal prawns, simple face mask, venturi mask, non-breathing mask, and NIV. So now we will discuss a little about these devices because this is also important while solving ABGs. This is nasal prawn. With this device, you can start with 1 liter to maximum of 5 liters per minute of oxygen. If the oxygen requirement increases further, then we have to start using a simple face mask. Suppose a patient on nasal prawns of 5 liters of oxygen, what will be the FaO2? You know that the room air is 21%. For a patient on nasal prawns, we have to add 3 to 4% of FaO2 for each liter per minute of oxygen to the room air FaO2, which is 21%. The value 3 to 4% is not that accurate because it can vary, but generally we use this for calculation purpose. So a person on 1 liter of oxygen in nasal prawns, the FaO2 will be 25%. So how you got this value? You add 21% plus 4%, so you will get 25%. So here the FaO2 of the patient on nasal prawns of 1 liter will be 25%. If the patient is on 2 liters of oxygen, what will be the FaO2? It will be 21 plus 4, that is 29%. So here the FaO2 is 29. So now you see this ABG. This patient is on 3 liters of nasal prawns, then the FaO2 will be 21 plus 4 plus 4 plus 4, that is 33. This is face mask. You can provide a flow rate of 6 to 15 liters per minute. Don't use a face mask if the oxygen requirement is less than 6 liters per minute. A minimum of 6 liters per minute of oxygen flow is needed to prevent the rebreathing of exhaled carbon dioxide. So what's the FaO2 of patient in face mask with 10 liters of oxygen? It will be 21 plus 10 into 4, that is 61%. So the FaO2 of the patient with face mask with 10 liters of oxygen will be 61%. This is venturi mask. A venturi mask is used to deliver a precise concentration of oxygen to patients. It is particularly useful for patients with COPD or other conditions that require controlled oxygen therapy. The mask can deliver specific oxygen concentration ranging from 24 to 60% depending on the need of the patient. Venturi mask is a color-coded adapters, each corresponding to different oxygen concentration. These adapters allow room air to mix with oxygen, resulting in desired concentration. Unlike simple face mask or nasal cannulas, the venturi mask provide a fixed and predictable oxygen concentration, which is essential for patients who are sensitive to changes in oxygen levels. The mask operates at different flow rates, typically from 4 to 12 liters per minute, depending on the adapter use. And this is non-rebreathing mask. A non-rebreathing mask is a device used to deliver high concentration of oxygen to patients in respiratory distress. It has a mask and a reserve bag. The mask is connected to an oxygen source, typically delivering 60 to 100% oxygen at a flow rate of 10 to 15 liters per minute. The one-way valve ensures that the patient inhales mostly oxygen from the reserve bag, minimizing the rebreathing of exhaled carbon dioxide. It provides high oxygen concentration used in acute respiratory distress, severe hypoxemia, conditions requiring high oxygen concentration such as pulmonary edema or severe acute exacerbation of asthma. This is NIV. This mask can provide up to 100% of FaO2. This mask fits over the mouth and nose and is connected to the ventilator that provide pressurized air. They help improve oxygenation and reduce the work of breathing. So now you know how to calculate FaO2 for each oxygen devices. So once more, how to read an ABG? First is validity, then oxygenation, then ventilation status, and last is ABG abnormalities. Validity we discussed. Second heading is oxygenation status. Here first you have to mention about PaO2. PaO2 is the partial pressure of the oxygen. I already mentioned that the expected PaO2 can be approximated by multiplying FaO2 by 5. The normal PaO2 is 80 to 100 and PaO2 of 60 to 80 indicates mild hypoxemia and less than 40 indicates severe hypoxemia. And in this patient the PaO2 is 30. So you need to mention in exam that this patient has severe hypoxemia. The second subheading is P/F ratio. Why do you want to do that? The P/F ratio, also known as the PaO2 by FaO2 ratio, is a measure used to assess the degree of hypoxemia in patients, particularly those with acute respiratory distress syndrome. P/F ratio is a ratio between the partial pressure of the oxygen and the fractional inspired oxygen. A normal P/F ratio is 300 to 500. It's used to classify the severity of ARDS and correlates with mortality. A ratio of less than 200 suggests significant respiratory dysfunction. You can see here the gradings of P/F ratios. Mild is between 200 to 300, moderate is between 100 to 200, and severe will be less than 100. A lower P/F ratio indicates more severe hypoxemia and potentially more significant lung dysfunction. So in ABG, first you have to mention about validity, second oxygenation status. In oxygenation status, we have discussed about PaO2 and P/F ratio. And now what is A gradient? A gradient or the alveolar oxygen gradient is a measure of the difference between the alveolar concentration of oxygen, as oxygen in the alveoli, and the arterial concentration of the oxygen. It is used to differentiate the source of hypoxemia. This patient is tachypneic, admitted in the emergency room and his SpO2 on room air is only 75. ABG is showing PaO2 of only 30. Here we have to calculate A gradient to differentiate the cause of hypoxemia. So A gradient, it is the difference between the amount of oxygen in the alveoli and the amount of oxygen in the artery. Can help differentiate whether the hypoxemia is due to the ventilation perfusion mismatch such as COPD or a shunt such as an intracardiac shunt like ASD or VSD. So first, how to calculate A gradient? A gradient is calculated by just subtracting PaO2, that is alveolar concentration of oxygen, minus PaO2, that is arterial concentration of oxygen. PaO2 we get directly from the ABG, and PaO2 or the alveolar concentration of oxygen we have to calculate from the alveolar gas equation, and this is the equation. Normal A gradient in room air is 15 and with 100% FaO2 it can go up to 150. After using this formula, for a normal person the value will be 15. Suppose this patient is admitted with hypoxemia and we calculate the A gradient. If it is high like 100, then give him oxygen. If his PaO2 improves, it means that he has a VQ mismatch like COPD, ILD or alveolar disease. But if his A gradient is high and after giving oxygen his PaO2 does not improve, it means he has a shunt such as an intracardiac shunt, alveolar collapse like atelectasis or intra-alveolar filling like pulmonary edema. In another scenario, if the patient has hypoxemia and his A gradient is normal, then check his carbon dioxide level in his ABG. If it is normal, his low PaO2 is due to either high altitude or reduced FaO2 for some reasons. But if the PCO2 is high, it could be due to hypoventilation caused by some neuromuscular disease. So A gradient is used to differentiate the cause of hypoxemia. It is the difference between the alveolar concentration of oxygen and the arterial concentration of oxygen. The normal value is 15. So once more, if the A gradient is high and PO2 improves with oxygen supplementation, consider VQ mismatch like COPD, and if oxidation does not improve, it could be due to shunt like AVM, etc. And if the A gradient is normal, then look at the PaCO2. If it is high, probably the patient is hypoventilating due to some neuromuscular disease. And if the PaCO2 is normal, then it could be due to low inspired oxygen or high altitude. Now the third heading is the ventilation status. Here look at the PaCO2. What's normal PaCO2? 40. If it is less than 40, for example 30, mention that this patient is hyperventilating. And if it is high, for example 60, mention that this patient is hypoventilating. So now we will try to read this ABG in a step-by-step manner. First, find out whether the ABG is valid or not by using this formula. H into bicarbonate by PCO2 should be 24. If you get 24, that means this ABG is valid. Second, look at the oxygenation status. In that, first is PaO2. PaO2 here it is 30. So the patient has severe hypoxemia. Then comes the P/F ratio. Here, if the patient is in the room air, the P/F ratio will be 30 divided by 21 into 100, that is 142, which is very low. So the patient has severe respiratory dysfunction. Now we have to calculate the A gradient by using the formula mentioned before. The third heading is ventilation status. Here the PCO2 is high, so the patient is hypoventilating. Now the fourth heading is ABG abnormality. Here we discuss acid-base status. In next part we will discuss ABG abnormality in details and start with metabolic acidosis including anion gap, delta anion gap, urinary anion gap. That's all for today.